nevertheless, we see, unfortunately, patients at a palliative stage. So the question is to know how to treat patients using endoscopy. There are, in fact, two parts in the small lecture. First part does concern bleeding, and second part does concern gastric outlet obstruction. First of all, bleeding, which is a frequent symptom related to gastric cancer at a palliative stage, and difficult to manage. So you just have to know that, in fact, the bleeding related to tumor does represent only 5% of upper gastrointestinal bleeding cases. But in fact, gastric cancer is the most common causes of tumor bleeding, more or less 50%. And bleeding is finally implicated in 1/3 of a patient at a palliative stage. So it is a relatively frequent symptom for patients at a late stage. And, but nevertheless, the patient, they're at a very advanced stage, because usually when they bleed from cancer, they had metastasis. So the life expectancy is quite short. Why patients are vulnerable and not so easy to manage? First of all, bleeding can, of course, come from the cancer itself, but sometimes patients have nausea, vomiting, for example, due to chemotherapy or due to gastric outlet obstruction. So it is very frequent to observe associated malariae or GERD, etc. So when you see a bleeding in a patient with a gastric cancer, don't forget that maybe the bleeding is related to another cause. And also the patients, they have coagulopathy. They can have coagulopathy due to bone metastasis and bone marrow invasion. And also they frequently have side effects due to chemotherapy, such as thrombocythemia. So there are plenty of factors which explain that bleeding can be severe and can be frequent. So do we need to assess initially the patient? Can we use the usual bleeding scores? In fact, in the literature, there were some controversial data, but more recently, it has been published, but nevertheless, the usual score, such as a Rockel score, can be helpful to predict the need for procedures, and including endoscopic therapy, as you can see, and transarterial embolization and surgery. So it can be effective. Also, what we call the Glasgow Bleacher score was superior in predicting the need for all interventions, including transfusion and other procedures. So, despite some controversy, you can use these scores. And these are the data from different publications using endoscopic therapy. We don't have so many data, and we don't have randomized study. We don't have prospective studies, in fact, only retrospective studies. And you see that the number of patients is highly variable, from 5 to more recently, more than 100 patients. And this is the success rate. Success rate initially is quite good. But nevertheless, you see a recent publication which was not so positive. This is the first problem. So success rate is acceptable, but not always 100%. And the main issue is related to the recurrence error, which is quite high. Of course, usually some studies, they don't have long-term outcomes, but when you have long-term outcomes, you see recurrence rate is quite high, between 40% to 80%. So this is the main problem. We all know that maybe we can treat a patient by endoscopy, but unfortunately bleeding can recur. And these are the different tools which has been assessed, used, and they are more or less classical, and they have been used also for ulcer, such as injection, mechanical treatment, thermal treatment, and more recently hemospray. So there is no comparative studies. So it's difficult to recommend one treatment. What I'm doing personally is I'm injecting more frequently ethanol in order to obtain an ischemia of the lesion. And I inject ethanol very deep within the lesion. Mechanical tamponade is applicable, but in fact it is only effective on localized, in case of localized bleeding, which is not frequent, in fact. Thermal is usually, especially using APC, is too superficial. So my main, in fact, my recommendation is mainly to use injection and, if possible, ethanol. More recently, we have hemospray. And you see some, at least the two largest studies already performed, but they included, in fact, not only gastric cancer, they included other cancers. So it is difficult to, these data are very difficult to analyze, and they only reported short-term results. And I suspect that hemospray is not so effective at a long term. The problem concerning rebleeding is that rebleeding is associated with poor overall survival in patients who achieve successful hemostasis for tumor bleeding, and especially in patients with early rebleeding. So rebleeding is very frequent and is associated to survival. And you see that the median overall survival for patients who bleed for gastric cancer at a late stage is very short. 4 months in those without rebleeding, 3 months in those with late rebleeding, and only 1 month in those with early rebleeding. So that means when the patient rebleeds, it does mean that the life expectancy is very short. So it has to be taken into account. So in summary concerning bleeding, so we don't have guidelines. We cannot recommend one instead of another treatment. I prefer to inject ethanol, but there are a possibility to use coagulation or clip for localized bleeding, but we don't have alternatives, in fact, apart maybe gastrectomy. But in fact, we don't have alternative, and unfortunately, the patient, they died very frequently, they died very soon following the bleeding. Now, gastric outlet obstruction, we have a first intent treatment, which is stenting. So the situation is more clear, and metal stent is deployed through the endoscope, as you know. The technical success rate is is excellent, 90–100%, and recently a review has been published concerning more than 1,000 cases with a very high success rate. Technically, it's not difficult, but the problem is related to the clinical success. Clinical success is defined by, of course, the relief of obstructive symptoms and improvement of oral intakes. And it is usually recommended to use this score. And using this score, in fact, the clinical success could be quite high in this large review, 89%. But you see that in some cases, this is not so high, probably due to early experience or due to stent migration, etc. There are, in fact, problems related to stenting. First one, carcinomatosis. When you have a carcinomatosis, that means you have maybe an obstruction at the level of the stomach, but you can have obstruction at the level of a small bowel. And so it takes, and in 155 patients in this series, in fact, they observe 38% of clinical failure due to carcinomatosis. So you should first perform a CT scan or MRI, but CT scan, in order to avoid to insert a stent in case the patient had multiple stenosis at the level of a small bowel. Second problem is access to the bile duct, because sometimes you have an associated bile duct obstruction, or bile duct obstruction can suddenly appear during the follow-up of the patient. So you should always try to, if possible, perform combined stenting. That means first bile duct stenting and then gastric stenting in case of bile duct obstruction. Or now there is a possibility to use a EOS-guided gastrohepaticostomy when you cannot insert the endoscope in the duodenum. The problem number 3 is related to chemotherapy, because initially chemotherapy was considered to be at risk of migration for the stent. And so there was a major concern. But finally, also chemotherapy does induce less risk of obstruction. And so the last publication states that overall it is acceptable and there is no major risk to associate stenting with chemotherapy, despite chemotherapy is more and more effective. Now, two last questions. If there is still a role for gastrojejunostomy in comparison to stenting. In fact, there are several publications, and you see people are still publishing on this topic, and they publish comparative studies, usually randomized more recently, but in the past, not randomized, just retrospective. So is there a role for gastrojejunostomy? In fact, possibly yes, because stent placement is associated with better short-term outcomes and fewer morbidity, lower morbidity. So for sure, at an initial stage, stent placement is interesting, but gastrojejunostomy is associated with better long-term outcomes and finally lower cost, at least in this recent study. So gastrojejunostomy is not totally abandoned, in fact, and can be a possibility, an option. Nevertheless, because of usual short life expectancy and because stenting is so easy, that stenting now is the gold standard and has replaced gastrojejunostomy. And in fact, most patients can continue oral intake until death. And you see that only more or less 80% require no further intervention until death. The problem is related to life expectancy, which is short, and finally, in large majority of cases, in fact, stenting is sufficient. And second question is covered versus uncovered stent. On one hand, covered stent increase the risk of migration and the risk of pancreatic and biliary obstruction in case you insert the stent very low in the duodenum. On the opposite, uncovered stent is associated to a risk of ingrowth and obstruction. So which is the best? In fact, there are at least 2 recent meta-analyses, and I selected one from 9 studies, more or less that represent 850 patients, and they observe no difference in all the factors: technical success rate, clinical success rate, post-stenting dysphagia score, stent patency, oral complication, reintervention rate. So no difference. So you can select both, in fact, and in fact, in my unit, we select a covered stent when there is no risk of obstruction of a bile duct. That means when when we can insert the stent and the distal part at the level of genus superius, at the upper part of D2, we prefer covered stent. And last advance, finally, does concern the fact that now we can, or we could, perform EUS-guided gastrojejunostomy. Now we have several publications, first in animals, and more recently in patients, published by Bowen Kashab, GI endoscopy recently, and out of 10 patients, they observed a success in 9 cases, technical success and clinical success, with a very low morbidity. So now, as endoscopists can perform gastrojejunostomy, maybe we'll see another competition between endoscopic gastrojejunostomy and endoscopic stenting. So this is my conclusion. In fact, all these issues are related and should be analyzed taking into account the fact that the patient will have a short life expectancy, especially if they have a gastric outlet obstruction, especially if they bleed. And so you should consider that maybe it's probably better to perform a very fast treatment, which with a very low morbidity initially. So for sure, concerning gastric outlet obstruction, basically stent has exactly the same role than surgery, but in fact, due to the fact that morbidity is very low, it is the first intent treatment. Concerning bleeding, we don't have so good treatment, in fact, endoscopic treatment, and there is a high rate of recurrence. I'm more personally in favor of ethanol injection, but this can be discussed. Thank you very much.
Dr. Ponchon, which volume of ethanol do you usually use in these cases?
Yes. I use, yes, you're right. I use pure ethanol, which is used by radiologists for other indication. I'm using maximum, at least the first approach, 10 cc, 10 milliliter. I inject 1 millimeter by small small sample of 1 milliliter. But I inject at different locations in the tumor and inject, yes, and very deep. And you can see sometimes that the tumor becomes whitish. So it means that it does induce an ischemia. And I've never observed any perforation due to this treatment. So I think this treatment is interesting because it is a treatment which has a prolonged effect because of ischemia, and you can treat the lesions very deep in comparison to other treatments. I tried, okay, but we need to assess this treatment now. And this is a very cheap treatment too.